Hello and welcome to this lecture. Today we are going to discuss amoebiasis, and I'm presenting the case of a 4-month-old male infant from a rural district in Iran. He was brought to the emergency room of the Lauriston University of Medical Science Hospital with a history of refusal of feed, hyperactive bowel, vomiting, and change in stool texture. The patient also had episode of uh, retching and mild abdominal distension. The mother suffered abdominal pain and had a history of diarrhea. The direct examination of the fresh fecal sample using Lugol iodine solution and the concentration technique showed the presence of Entamoeba histolytica, cyst and trophozoites with red blood cells and many leukocytes. So this is the case presentation and the figure showing you the presence of cyst and trophozoites of Entamoeba histolytica, which is a causative organism, and the table giving you the presence of the information about how many eosinophils, hemoglobin concentration, and other CRP protein, which is usually positive in patients like this. So it is another good marker for identification. Causative organism, as we already discussed in the case, Entamoeba histolytica can be contaminated through fecal, oral, and anal sexual practices. And the parasite can be occur in two forms. One is the trophozoite form, and the second one is cystic form. So it can be appear either as in the form of trophozoite or it can be occur in the form of cyst, and can be found in the diarrheal stool. Morphological features consist of amoebic colitis, amoeboema, amoebic liver abscess, spread of lesions to other sites. So the main thing is that because it can metastasize and it can travel to other parts of the body, so it can travel to the brain and can cause brain abscess, or can travel to the lungs and can cause lung abscess, or liver abscess, or colon. So it can lead to colonic ulcers, or amoebic colon, or liver abscess, or subdiaphragm abscess. So where it travel, it can causing the abscess formation or ulceration. So the main thing that obviously the ulceration will be occur, so there will be a necrosis, and especially necrosis of mucosa, and there will be the enlargement of the ulcerative lesions. So the trophozoites will perform the lytic action and it can cause chronic amoebic ulcers. As a result, there will be the inflammatory response, and then in inflammatory response we will have the mixture of polymorphonuclear cells as well as mononuclear cells, along with the presence of trophozoites of Entamoeba histolytica. These arrows showing you the presence of amoebic colitis and the round structures. And I know the structures look like very similar, but they are not similar because they are stained with different staining techniques. They look similar, but they are different. So these round structures, if you see these compare with all of them, they are actually similar, and these actually they forming the amoebic colitis. And obviously the section also showing you the presence of ulceration and inflammatory infiltrates also present. And the arrow is actually showing you the presence of all Entamoeba histolytica. So the main thing is that these round structures showing you the presence of the Entamoeba histolytica, and this picture is going you to explain about the amoebic colitis that consists of ulcers, amoebic ulcers, necrotic debris, acute inflammatory infiltrates. So the clinical course consists of amoebic colitis is usually gradual in onset, leading to diarrhea, patient having crampic abdominal pain, watery or bloody diarrhea, weight loss, anorexia. Fever will be noted in 10 to 30 patients. The predisposing factors will be one of them is the poor nutrition, along with the pregnancy or the use of a drug such as corticosteroids, and sometimes at very young age. So what is the relationship of the corticosteroids and amoebic colitis? Let's discuss. To understand the role of the corticosteroid, first you need to understand the fulminant amoebic colitis, which is a rare complication of amoebic dysentery, usually occur less than 0.5% cases, and it presented with a rapid, severe bloody diarrhea. Usually, the amoebic colitis is not rapid, but in fulminant amoebic colitis, the onset will be very severe and fast, and severe abdominal pain, and the evidence of peritonitis and fever. To understand that comparison, or to understand the relationship between fulminant amoebic colitis after corticosteroid therapy, this is an article that I found to explain in detail. And this is a systematic review that are discussing about the corticosteroid therapy and fulminant amoebic colitis. In the background, they discuss about a causative organism that is causing that disease, which is Amoeba histolytica. They are discussing about the findings and discussions. They mentioned that infection with Amoeba histolytica should be considered prior to the administration of corticosteroid, in particular patients for residing in endemic areas or those with appropriate travel history, especially prior to the diagnosis of inflammatory bowel disease. So the main thing is that we need to evaluate the infection with Amoeba histolytica first, and then we need to give them the corticosteroids. The assessment will be very important. When we read the conclusion of the study, you can read the full article in detail, but the main thing that they found that 24 cases of patient who develop severe and fulminant colitis following treatment with corticosteroid therapy. So it means that they start with a treatment of corticosteroid, but with the corticosteroid, they develop fulminant colitis, and emphasizing high morbidity and mortality associated with the condition, identifying the knowledge gap that must be addressed. So this is very important. They're mentioning that the corticosteroid therapy is not good when they're treating this patient with amoebic colitis. Still, they have not mentioned the reason that why this occur, but they mentioned that usually this infection occur in endemic area, and the proper diagnosis is very important for a patient having Amoeba histolytica before giving the treatment of corticosteroid. So you can read this article, and they recommended some of the findings, which they mentioned that patient with either symptomatic or asymptomatic intestinal amoebiasis treated with corticosteroid therapy at high rate or high risk of developing potential fatal complication of fulminant amoebic colitis. So I already mentioned that fulminant amoebic colitis could be highly chance to become if patient treated with corticosteroid therapy. Diagnosis is very important, whether the infection with Amoeba histolytica or before you need to take any decision. Travel history of patients, close household sexual contact should be obtained prior to initiate systemic corticosteroids. Patient residing or traveling history to an endemic part is another important thing, like Southeast Asia, Africa, Central America, South America, Mexico should be screened for amoebiasis and test. And all patients with evidence of Amoeba histolytica infection should be treated appropriately prior to initiating corticosteroid therapy. So corticosteroid therapy is not the initial therapy they are discussing. It could be treated, they mentioned, with the metronidazole, which is a drug, or you can use paramomycin. So the main thing is that we need to discuss, see the patient condition, not treating with the corticosteroid initially. We will discuss in detail later on in our upcoming lecture. So you can read this article. This is very interesting article about fulminant amoeba colitis and after corticosteroid therapy. So when discussed about the pathogenesis of amoebic liver abscess, obviously there will be ingestion of the cyst that travel to the small intestine. We mentioned the excistation or in small intestine, then the production of trophozoites These trophozoites will be multiply and colonize in the large intestine. After the large intestine, it can cause tissue invasion and destruction. They are then responsible for flask-shaped ulcers, mostly in the cesium transverse and sigmoid colon. And then we have encystation and exit from the host in the stool. And then, or they can migrate through portal vein and then spread to the peripheries. So portal vein, liver hepatic portal vein is very important site because it is responsible for the travel of these cysts to other parts. And then they start with the excitation in the small intestine, but they end up with the encystation that exit through the stool. So through stools, it can then travel and spread. That is why it is endemic, because if someone have this disease, it can spread where poor, you can say, hygiene is one of the key factors. Microscopically, the lesions consist of inflammatory granulation tissues, fibrosis, and cluster of trophozoites will be formed. So this is a picture how macroscopically it look like, and in amoebic liver abscess, it look like round structure, the white round structure, and they are usually solitary, mean confined to the one area located on the right lobule of the posterior superior part. The size will be greatly varies, usually about the size of an orange. So you can see this is a quite big size in nature. Then they are yellowish gray amorphous liquid material, and they are identified at a junction of viable and necrotic tissue. So these are the important characteristics that will be found. And I already mentioned that it can be through hepatic portal vein. We know that this portal vein is very important because it can go to peripheries, they can see all, and then through hepatic portal vein it can spread to intestine and to different parts. It can travel to brain, so that is very important. This is a picture to see that where it can stay. So it can stay into the posterior superior segment, as we mentioned here, like posterior superior part. So the posterior superior part is, you can see that the upper segment of the liver, whereas anterior lateral is the lower segment. So it occurs usually in the upper segment. The other sides, it could be affected, like it can be peritonitis performed by perforation of amoebic ulcer to colon and extensive lungs. I already mentioned this thing. It can reach to pleura, it can lead to liver, it can be hematogenous and spread to cause amoebic carditis. It can reach to the heart and inflame the myocardium, then the cerebral lesions. So I already mentioned it can spread to other parts like this. This is another picture talking about different spreading area: lungs, brain, liver, spleen, in the colon, in the liver, in the pleural spaces, in the lungs. So you can see the look. This is already discussed before. So thank you so much for today's lecture. Hope to see you again.